Now I would like to ask Professor Alexandre from Brussels, Belgium, to present the topic of impact of wars on as a part of environmental human being scenario. Alexandre, the floor is yours.
Thank you for a kind introduction. So today I will speak to you about an underestimated aspect of environment, that is psychological environment. And my talk is about war, hypertension, and PTSD syndrome. You may think that I am here a bit an outlier, but I will try to convince you that this is not the case. Sorry. So this picture is from Salvador Dali from 1936, and it's about war, civil war. Unfortunately, it's still something very contemporary thing to Gaza, Ukraine. And so war brings the most drastic change in environment. Basically, the world can become a desert, as seen here. And as you can see as well, it can have consequences on the health, both mental health, look at the face, and physical health. It's true that war, here the example is Ukraine, can impact all aspects of environment in the generally understood meaning of this term. It can also affect all elements that were previously covered by the speakers in this first session: pollution, noise, light, things to bombing, people going to shelters, not sleeping during the night, etc. But also, it leads to important lack of access to healthcare, anxiety, stress, depression, and post-traumatic stress disorder. And I also mention my take here is that a psychological environment is at least as important as environment linked to other sources. The World Health Organization has estimated that 1 in 5 people who have experienced war or other conflict will have depression, anxiety, post-traumatic stress disorder, bipolar disorder. And in applying these estimates to Ukraine, next door to here, the WHO expects that approximately 10 million people in Ukraine may have a mental health condition. But besides this, there are the physical effects of war. And this is an editorial in European Heart Journal by investigators living in Doha, so they know what they are speaking about in the Middle East, and about the potential effect of both conventional weapons and weapons of mass destruction on health, and particularly cardiovascular health. And part of these cardiovascular health issues, many of them, are in fact related to post-traumatic stress disorder, which has been associated to basically all cardiovascular risk factor and disease, including hypertension. What is PTSD? PTSD is not about acute stress disorder. For sure, if you are exposed to acute violence, you might have a rise in blood pressure. It is about symptoms that persist for at least 4 weeks, and you should have at least one from 4 different clusters. Intrusion symptom, for example, having flashback of the difficult event. Cognition and mood symptom, trouble remembering the traumatic event. Experiential avoidance, avoiding place where it happened, or arousal and reactivity, for example, sleep difficulties, anger, and irritability. And PTSD beyond war, it happens lifelong in 7 to 8% of the adult population, is more frequent though understudied in women, but for sure affects more people such as military servants, refugees, or people living in the war. And it's an invisible scar, but can be also lead to visible sequelae and very concrete consequence in people's existence. Is it then a fatality? You are exposed to war, you develop PTSD, and then you will develop psychological and cardiovascular or physical consequences? Not really, because there is a complex interplay between PTSD on one side and the way you are able to regulate your emotion. And this can be partly learned, partly managed by appropriate follow-up. If you develop this situation of avoidance, negative appraisal, rumination, blaming other and yourself, the PTSD becomes chronic, you somatize, and finally you may develop physical disease. If, on the contrary, you are able, with help of professional, to develop positive emotion-related factors, to reappraise the situation, to learn something from there, etc., to go forward, then the PTSD may last less and have less untoward consequences. Our interest in this came from study of patients with apparently treatment-resistant hypertension, and we found in several studies a relation between both degree of drug adherence and severity of hypertension irrespective of drug adherence with exposure to trauma, PTSD feature, but also the way you handle emotion, as already mentioned. And a significant minority of these patients were migrant and refugee with a history of trauma. If you would like to have a more, let's say, living idea of how military servants may develop PTSD, please read this editorial by Admiral Dr. Bronze, which was been published by Blood Pressure. Michel Bernier, the editor, is here. Is really very important. But we can also look to other scientific publications, especially from the US, showing a relation between the chronicity of PTSD, how long it lasts, and the incidence of hypertension in veterans from war, for example, in Iraq or Afghanistan. And you see there is an independent effect of the severity of wounds received by military servants and the chronicity of PTSD and incidence of hypertension. So again, with the same terrible situation, the same wound, you may evolve differently according to psychological assets and the help you may receive. Also, some people with PTSD then tend to be non-adherents, and this is part also of the problem in people exposed to war, besides not having access to healthcare. Sometimes I'm asked, why do you speak about this if we cannot do anything about this? Well, there is fragmentary evidence that managing the PTSD with professional help, including this regulation of emotion, medication, psychology, may limit also the physical consequence, including development of hypertension. Another place where war is or was until recently there is East Congo in Belgium. We know this very well. And so we perform in Bukavu with psychiatrists a case control studies looking for factors associated with hypertension in this place of the world. And again, the main factor associated with hypertension in this series were not family history, not BMI, not fasting plasma glucose, but trauma, significantly man-made trauma, and this is about war, and PTSD, and also the relation was again modulated by cognitive reappraisal, the way you can handle your emotions. And you can see there was a follow-up study, a past analysis approach, showing that this relation between human-made traumatic event, PTSD, and then hypertension can be modulated by regulation of emotion, but also, and this is new in my talk, social support. Please keep this in mind. If you have some social support, you may be less at risk. The third population, you have military servants, civilians exposed to war, and then there are the refugees, who can be civilians who fled their country. And these people, as shown in this meta-analysis, they have a very high prevalence of PTSD. In most studies, 30 to 40% compared to less than 10% in the general population. And in these people, in my opinion, they have a kind of two hits. First, there is a trauma of exposure to war, and then there are the challenge of displacement, because displacement might be the solution, but first is not always chosen, and then when you are there, between others, you have not the social support, maybe no job, etc. So it's a second challenge in reality. And so I would like to showcase again the program that was established by Krzysztof Nakiewicz and Michel Burnier, and we're invited in this to look for the effect, the association of PTSD and psychological factor with hypertension in women refugees in Gdansk, Poland. And things are going now to large number, but again I will show you our pilot study showing that the prevalence of PTSD in this group was high, and all patients with PTSD but one were hypertensive. Along the same lines as I've said about these two hits, many of these women still did not feel safe in Poland. And this is about the challenge of displacement, but also the persistent PTSD. And there was a relation between safety perception and hypertension. The less safe, the highest prevalence of hypertension, and between safety perception and PTSD. And finally, the severity of PTSD-related symptoms, particularly re-experiencing trauma and hyperarousal and increased reactivity, was shifted to more severe in the hypertensive women in Poland. And I hope I could show you the large-scale results. It's still not ready, but it's in good progress, maybe next year. Finally, we come to a kind of tentative model. You see, there is war. War is the most drastic change in environment you may experience. This may lead to the development of PTSD, and through both unhealthy lifestyle, poor drug adherence, lack of access to health care on one side, and insufficiently defined but likely mechanisms such as inflammation, activation of renin-angiotensin system, sympathetic nervous system, you may develop hypertension, cardiovascular, and metabolic disease. Again, this is not an absolute fatality. And so the way you handle your emotion may contribute to worsen, or on the contrary, to improve this situation. And so it's our role as doctors to help these people to seek professional help from psychiatrists and psychologists. And finally, there has been a recent emphasis on improving environment, pollution, noise, light to prevent hypertension. And the working group led by Professor Reiser and this meeting are the perfect evidence of this, and it's very good. But I'm making here a plea to extend this conception of environment to healthy psychological environment. Not being exposed to war would be, in an ideal world, a minimum. But also, people should not be exposed to physical violence in general, to harassment, bullying, burnout, which are so frequent in our societies. So maybe another time I can try to develop this, how to improve psychological environment, even in society in peace. Thank you for your kind attention.